Bueno, vamos a arrancar a las 11 debido a que, pues, para no atrasar el programa, y hay otras presentaciones después. Es para mí un placer presentar al doctor Isaac Teitelbaum. El doctor Teitelbaum es profesor en la Universidad de Colorado, en la Facultad de Medicina, en Aurora, Colorado, olvido ya. Y él es parte de la Sociedad Internacional de Diálisis Peritoneal y ha tenido sus ganas de venir aquí a este simposio para deleitarnos con una nueva charla que es sobre nuevas indicaciones de diálisis peritoneal, que va a ser una charla muy interesante para todos nosotros y sobre todo para los que trabajamos en diálisis peritoneal. Entonces quiero darle la bienvenida al doctor Teitelbaum, ya es ampliamente conocido, para dar inicio a esta conferencia.
Good morning, everybody, and thank you, Rafael. Thank Dr. Bernardo. It's a pleasure to be here. My thanks to the organizers of the conference for inviting me. We're going to talk about some very unusual potential uses for peritoneal dialysis. I promise you, anything I say today, you will not be using in the next 3 to 5 years. This is different stuff. Disclosures, all of them irrelevant to today's presentation. Oop. So, by way of introduction, we know that peritoneal dialysis for end-stage kidney disease is used in about 11% of the patients worldwide. We know that there can be use of peritoneal dialysis for acute kidney injury that is done in Africa, in other low or low middle income countries. There's been exploration of the use of peritoneal dialysis for congestive heart failure, for hypothermia, pancreatitis, even psoriasis. But I'm going to talk about two even stranger things. We'll talk about the potential use of what's called liposome-supported peritoneal dialysis, and then we'll turn our attention to discuss the potential use of peritoneal dialysis as a therapeutic modality in patients with a stroke. So let's start with liposome-supported peritoneal dialysis. So first of all, what's a liposome? So a liposome is a spherical nanometric particle, so a very, very small particle, composed of a phospholipid bilayer surrounding an aqueous core. Liposomes have been used for the delivery of drugs or genetic material, and sometimes this can be targeted delivery if the liposome has an antibody directed against a specific antigen, so that will home in to that tissue, and you can target the liposome to a specific tissue. But what we're going to do is talk about using the liposome as a potential scavenger for toxins. If you adjust the pH of the aqueous center, for example, you can acidify the core of the liposome, and then basic molecules that enter will be protonated, will be trapped, and if you can get rid of the liposome, you can get rid of the toxin that is trapped within it. You can administer liposomes intravenously, and they are effective at sequestering toxin or drugs like verapamil or amitriptyline. The problem is two things. Number one, there's what's called CARPA, complement activation related pseudo-allergic reaction. It's a big mouthful, but what it means, it's sort of like anaphylaxis. It's not IgE mediated, but it's a hypersensitivity reaction with facial flushing, chills, headache, and cardiopulmonary distress. So that's not a great thing. And the other problem, the bigger problem with the liposome, is that while you can introduce it into the circulation, it's difficult to get rid of it. And that's why people came up with the idea of exploring liposome-supported peritoneal dialysis. Remember, small molecules like toxins will diffuse freely across the peritoneum and they'll get into the peritoneal fluid. You introduce a liposome with a transmembrane pH gradient, put in a PD catheter, introduce the fluid with the liposomes, they will trap the toxin, and then it's easy to drain the abdomen and get rid of the fluid with the liposomes in it. The liposomes are pretty, even though I said they're small particles, but compared to the pores within the peritoneal cavity, the large pore is 250 angstroms. The liposomes are more than 30 times as large at 8,500 angstroms. They will not get into the circulation. And because they don't get into the circulation and because there's very little complement within the peritoneal cavity, you don't have this problem with CARPA, the pseudo-allergic reaction that we talked about. So there's the liposome. We can use liposomes for exogenous toxins or endogenous toxins. Let's look a little bit, we'll start by looking at the exogenous toxins. Generally, if you have a patient with an overdose, what do? You supportive care, you might give them some activated charcoal orally to prevent further absorption, to decontaminate, and we try hemodialysis to remove the toxin. But not all toxins are available to hemodialysis, right? If something is highly protein bound, if something is very lipophilic, it's not going to be available for hemodialysis. And if the toxin causes hemodynamic instability, that's going to make hemodialysis difficult. You might be able to do continuous renal replacement therapy, but that's going to have less efficiency of removal of the toxin. And an example is verapamil. It's 89% protein bound, so it's not going to be readily available to dialysis. And what's not protein bound is lipophilic. So there's no antidote, it's difficult to remove, and it causes hemodynamic instability. So hemodialysis isn't going to be a very effective tool. Can we do liposome-supported peritoneal dialysis? So here's a study in rats. Verapamil is administered 50 milligrams per kilo. That's a pretty big dose of verapamil. PD or liposome-supported PD is initiated an hour later, and then if you look at the y-axis, you can see that it's discontinuous, and you can see that the removal of verapamil by liposome-supported PD is about 80-fold compared to regular PD. So introducing those liposomes, you remove 80 times as much of the verapamil. The left panel shows you the time course of blood pressure. This is mean arterial pressure as a percent of baseline. And on the right panel, you can see that if you leave animals untreated, it takes about 20 hours till they regain hemodynamic stability. If you do conventional peritoneal dialysis, it's the same. But if you do liposome-supported peritoneal dialysis, it goes down to about 6 hours. So it's effective at removing the toxin and restoring hemodynamic stability. And the same is true for other toxins. If you look at, on this slide, amitriptyline, you have propranolol, amitriptyline, I can't read which the third one is. The last one is phenobarbital. I think it's haloperidol. And you can see that, I can read it here. You can see that the removal of the toxin with liposome-supported PD in every instance is higher than with conventional PD alone. What about endogenous toxins? And here we can look at ammonia, and we can look at protein-bound uremic toxins, maybe a little greater interest to us. As we all know, hyperammonemia may develop in patients with hepatic dysfunction or inborn errors of metabolism. It can lead to confusion, cerebral edema. What do? Usually we manage it medically with lactulose or rifaximin to try to enhance the excretion through the GI tract, right? And get rid of the bacteria, less formation of ammonia. And we can do kidney replacement therapy. What if you have an infant? What if you have someone with hemodynamic instability? You can't do hemodialysis or may not be easy to do. So again, liposome-supported PD. Ammonia is lipophilic, weakly basic, so if you can acidify the liposome, you can get ammonia into it and remove the ammonia. Does that work? Well, let's focus here on the in vivo. Look at the circles. If you look at conventional PD, and I'm sorry I don't have a pointer, but if you look at conventional PD, the bottom line, you can see that there is very little removal of ammonia in 4 hours with PD. In contrast, it's markedly enhanced. If you look at the top line, this is in vivo, in rats, marked enhancement of the removal of ammonia with liposome-supported PD. This was maintained in the presence of acidic fluid. It's been done in a mini pig, okay? No carpo was observed. What about man? Can we do this in man? So there's been a single preliminary study, cirrhotic patients who received a dose curve, if you will, a dose finding study, different doses of this compound VS101, which is liposomes for PD. And then they received 4 consecutive doses at intervals of 2 to 3 hours. The bottom line, no serious adverse events, and the next to the last bullet, it significantly improved psychometric test results, increased the peritoneal fluid clearance of ammonia, and reduced plasma ammonia levels. This is a study in man. 3 patients, one way, 3 patients, a total of only 6 patients. This was published as an abstract in Hepatology. I don't know when in 2021, but a year and a half ago. And the issue is that it hasn't been published beyond abstract form just yet. So I don't know where this stands. As of, well, today's what, Friday? So as of Monday, it had not yet been published. Now let's turn our attention to protein-bound uremic toxins. These, by definition, are uremic toxins that are heavily protein-bound. Examples are precresal sulfate, indoxyl sulfate, indole 3-acetic acid. They're associated with infection, cardiovascular disease, mortality, and they're usually cleared by secretion in the proximal tubule through the organic ion transporters. However, CKD, there's lower GFR, less secretion. So we're stuck with these protein-bound uremic toxins. They're not cleared well by standard dialysis. They have a very high volume of distribution. They're, by definition, protein-bound, so there's very little available for dialysis. You can try to adjust in hemodialysis by getting a larger dialyzer and a higher dialysate flow rate. In PD, conventional PD, there's really no room to adjust. So you can try this bound solute dialysis. Add something to the peritoneal dialysate to act as a sink to encourage movement across the membrane. And this could be either albumin or liposomes. I'm not going to go through each of these individually, but you can see here that if you look at precresal sulfate, indoxyl sulfate, the 3-IAA, serum levels come down, dialysate levels go up. Albumin is better, more effective than the LSPD for some of these compounds, but albumin is also significantly more expensive. So on a risk-benefit ratio, you were better off using the liposomes, and it has the potential for the removal of both exogenous toxins and endogenous toxins. I have not seen any human trials yet for these compounds. Let's turn our attention to what I think is the more exciting aspect, and that is the potential, keyword is potential, for the use of peritoneal dialysis to treat patients with stroke. So why would you think of doing that? What are you removing that's going to be beneficial to a patient with a stroke? So glutamate is an excitatory neurotransmitter. Remember, it's an amino acid, so it's a small molecule that is involved in numerous physiologic reactions in the brain. And don't, in the question period, I don't think anybody will, but don't question me on the physiology of glutamate in the brain. I only know what it says on the slides. I don't know anything more. But it's stored in vesicles. Its release and reuptake are tightly regulated to maintain glutamine levels within the cerebrospinal fluid at very low, just less than 2 micromoles. Plasma glutamate is high, and the glutamate concentration in brain tissue is higher still. So it means you have the CSF, in a sense, trapped between the plasma and the whole brain fluid, and we have to keep the concentration in that extracellular fluid very, very low. And that requires active transport out of the CSF in each direction. So in stroke, glutamate accumulates in the extracellular space because this active transport mechanisms fail. This causes propagation of ischemia. This causes toxic effects on metabolically viable tissue, and through a series of pathways, reactive oxygen species, inflammation, and uncoupling of oxidative phosphorylation, you get apoptosis, you get cell death. And the bottom line is, it has been found that increases in the blood concentration of glutamate that ensue after a stroke are associated with disease progression. So if you have higher plasma glutamate after a stroke, there is more disease progression and more neurological damage. So of course that raises the question, if we can lower plasma glutamate, will that result in attenuation of the degree of injury from the stroke? And if the answer is yes, can we safely accomplish the lowering of plasma glutamate without exacerbating the brain injury? So here is a glutamate scavenger, this glutamate oxaloacetate transaminase. And what it does is it transforms glutamate to 2-ketoglutarate and aspartate, leading to a decrease of glutamate in the blood. And here's a rat study. You take a rat and you occlude the middle cerebral artery of the rat. The rat gets a stroke in the distribution of the middle cerebral artery. Glutamate levels go up, as shown in the upper line here. But if you treat the animal 1 hour after injury with GOT, this glutamate oxaloacetate transaminase, you lower or prevent the increase in plasma glutamate levels. And here you can see that if you infuse the GOT, it decreases the infarct volume, shown on the left, and it decreases the area of edema, shown on the right. You would think that someone might have tried an infusion of GOT in man based upon this. I haven't found it. What about physically removing glutamate by dialysis? It's a small molecule. It's an amino acid. It only weighs 147, right? Creatinine weighs 113. We do a great job of removing creatinine. Glucose weighs 180, and glucose, we know, moves across the membrane in the opposite direction. So obviously something at 147 should be removable with peritoneal dialysis. We could try hemodialysis, but hemodialysis in a patient with a stroke, do you want to risk the hemodynamic instability? Do you want to risk the lowering of cerebral perfusion? Do you want to risk rapid changes in osmolality, which could predispose to cerebral edema? Peritoneal dialysis in the setting of acute stroke is safer than hemodialysis. So Here again is the same model of P stands for permanent. So permanent middle cerebral artery occlusion. And you can see on the left that plasma glutamate goes up. On the right, and down on the bottom, the red line shows you plasma glutamate going up, and the blue line is if you do dialysis. And on the right is the plasma glutamate when you do dialysis, but you also infuse glutamate. And you can see that you overcome the ability to dialyze off the glutamate by infusing glutamate. That's going to become important on this slide. So on the left, on the top, is a diagram, if you will, or a cartoon of a rat brain. And you can see the infarct is shown in gray. So if you do a sham and normal animal, there's no infarct size. If you perform the middle cerebral artery occlusion, you can see the infarct on what is, for us, the right side of the diagram. If you dialyze the animal starting at 2.5 hours after peritoneal dialysis, 2.5 hours, so that's realistic, right? In 2.5 hours, you'd think you can place a catheter and get dialysis started. And you still markedly attenuate the infarct volume. You can prove that it's the glutamate that is important, because if you do the dialysis and give glutamate, this is now the green panel there, you can see that you again have an infarct size. And if you wait 5 hours, you can still diminish the infarct size. And on the right-hand side, they're simply looking at the infarct volume as a function of the plasma glutamate concentration. So again, what about in man? So this is a preliminary study that was done in Israel. It's not a particularly great study, and they took 18 patients and they did one exchange with peritoneal dialysis, and they removed some glutamate. Not a fantastic study. But here's a more important study where they had patients with stroke. They looked at their time on dialysis and measured serum glutamate on the left and dialysate glutamate on the right. And you can see that serum glutamate fell to around 60. And by 4 hours on dialysis, the D over P was almost 1. The dialysate glutamate was nearly 60. So you can effectively remove glutamate and get it into the dialysate. So obviously, we're looking for a clinical trial. Can you effectively treat someone with a stroke with peritoneal dialysis, remove the glutamate, and enhance their neurological outcome? One study conducted in Madrid, they randomized 10 patients with acute ischemic stroke, 5 control, and 5 are supposed to get the treatment. And the problem is that you didn't have 5 patients getting the treatment. Only 1 out of 5 patients received the full PD treatment. 1 patient had a misplaced catheter and got no PD, and then 3 patients, there were technical problems, and they completed only 1 to 2 exchanges. So this obviously is a serious problem with this clinical trial. But if you do an intention to treat analysis of all 5 patients, even including the one who had no peritoneal dialysis, there was still a 46% reduction in serum glutamate within 2 hours. Not significant. If you exclude that 1 patient who got no dialysis, then there was a significant, statistically significant reduction in serum glutamate. And again, only 1 patient got treated, so overall, there was no change in neurological function or infarct size. However, that 1 patient who did get 24 hours PD had a good neurological outcome at 3 months. There's what's called the Rankin score, which is used to stratify outcomes of patients with a CVA down the road, where we all hopefully have a Rankin score of 0. If we've had a CVA but function very well, it's 1. And then with progressive levels of dysfunction, it goes 2, 3, 4, 5, and a Rankin score of 6 means the patient died. So 1 through 5 for level of function after a CVA, the patient would have been expected, based upon the nature of the injury, to have a score of between 3 and 5, and the patient had a score of 1. Okay? And they say that the likelihood of having a score of 1, given this injury, was spontaneously, without treatment, was only 2%. Obviously, this requires more study. But peritoneal dialysis does appear to lower serum glutamate levels in patients following an acute stroke. The technical considerations are the issue. You would need to have, just like we have a stroke team that can very quickly insert a catheter and give TPA, you would need to have a stroke team that can very quickly insert a PD catheter and get peritoneal dialysis going. Is this realistic? I don't know, but the data is certainly very promising, and I'd love to see someone do a follow-up study. So, PD in the acute phase of stroke may be beneficial in limiting the extent of damage. Obviously, for all of these things, much further clinical study is needed before implementation of PD for these conditions can be considered. For those of you who want to learn more about peritoneal dialysis, I invite you to Dubai in September of next year. And I thank you very much for your attention. It's been a real pleasure being here.
Muchas gracias, Dr.
2 minutes for
Teitelbaum.
questions?
Yeah. Tenemos algunas preguntas del auditorio para el Dr. Teitelbaum. Javier.
Sí, muchas gracias, Isaac, por la discusión sobre los beneficios de usar la diálisis peritoneal como vía de entrada o como motorización de tratamientos distintos o particulares para patologías diversas.
Javier, again, please.
Sí, le estaba diciendo muchas gracias por presentar otras oportunidades de tratamiento para patologías distintas de la enfermedad renal crónica que pueden ser de provecho o de beneficio con diálisis peritoneal. Yo le quería preguntar si sin tener que ir a las patologías extrarrenales como el stroke o la intoxicación con medicamentos para inocular los liposomas o la albúmina con algún producto que remueva el tóxico o el veneno que está involucrado, uno no podría imaginar en diálisis peritoneal estándar utilizar algún sistema parecido a este, ya no solo para remover elementos extraordinarios como venenos o drogas, sino moléculas medias unidas a proteínas, como ya usted dijo, el cresol, el indoxilcresol y todas esas moléculas que sabemos que son moléculas urémicas, que no medimos habitualmente, pero que sabemos que están ahí y que conforman el síndrome urémico que nosotros conocemos. Entonces, ¿por qué no pensar en la diálisis peritoneal no solamente para eventos extraordinarios, sino para el de todos los días, tratando de expandir o de mejorar la diálisis peritoneal tal como la hacemos en este momento? Y a propósito quiero recordar que, por ejemplo, en hemodiálisis, esto ya ha sido explorado, creo que por el grupo mexicano, con la utilización de, por ejemplo, este antiinflamatorio tan conocido, que es el ibuprofeno, utilizando el ibuprofeno para captar las moléculas urémicas que están pegadas a proteína. Entonces, uno puede hacerse todo tipo de imaginación.
So, you're absolutely right, and we should be thinking in these terms. I wouldn't advocate using ibuprofen in patients with peritoneal dialysis because we want to save their residual kidney function. But we should absolutely be studying the protein-bound uremic toxins in these patients. I agree with you 100%, and more study is needed.
Una cosita más, y no tanto miedo al ibuprofeno, no para dárselo a pacientes que tienen función residual, pero a aquellos que no la tienen, no está mal el ibuprofeno como antiinflamatorio, y no me extrañaría que tuviera efectos muy benéficos para el envejecimiento de la membrana peritoneal.
¿Alguna otra pregunta? Si no, yo tengo una pregunta para el doctor Teitelbaum. ¿Los liposomas generan algún efecto osmótico a nivel de… un efecto osmótico a nivel peritoneal?
You know, that's a great question. I did not see any data about that. I don't know.
Bueno, creo que no alcanzamos
I
una.
would guess, if I can just, I would guess that the answer is no, because they're pretty big. I mean, they're compared to albumin. Albumin is 37 angstroms. These are 8,500 angstroms. So I think the osmotic effect would be negligible, now that I think about it.
Bueno, creo que no tenemos más tiempo. Muchísimas gracias y algo, pues el doctor Teitelbaum está disponible para las preguntas ya individuales. Muchísimas gracias. Gracias, doctor Teitelbaum. Excelente.